Up Close with Chris Williams is presented by Tennova Healthcare, with 6 hospitals and more than 1,000 dedicated physicians. For more information, tennova.com.
Welcome to Up Close. I'm Chris Williams. It appears almost every citizen in Tennessee suffers from some type of sinus problem. We spend a great deal of money and time attempting to treat sinus issues. Well, perhaps a new technology to treat our sinuses will provide what you or someone you know really needs to treat sinusitis and other sinus issues. Dr. Leonard Brown is a board-certified ENT, or ear, nose, and throat physician. He has performed thousands of procedures, both surgical and non-surgical. Sitting down with him, I wanted to learn what actually led him into his chosen profession. But first, I asked about his early days, both personally and the early days in his career. Dr. Brown, I wanted you to first of all go back, and for our viewers at home, tell them a little bit about your educational background and training.
Absolutely. Thank you so much for being here.
Sure.
I'm a native Tennessean. I went to undergraduate at University of Tennessee at Martin, studied zoology. From there, I went to medical school at Memphis, University of Tennessee at Memphis, and subsequently I owed Uncle Sam some time. So I did my residency at San Antonio at Brooke Army Medical Center, which is actually the home of the Army Medical Corps, and did that in ear, nose, and throat. After paying Uncle Sam back, I got out, moved to Memphis for a couple of years where I was involved with a pediatric fellowship, and then after that relocated to Knoxville. And I've been here for 21 years.
You say native Tennessean. Where did you grow up? Where was you
West Tennessee, a little town called Milan. Milan's claim to fame is it's the only city in America that has had 2 presidents for the University of Tennessee. One of them was Andy Holton, the other one was Eli Fly.
So was there any doubt that you wanted to practice in Tennessee one day?
No, Texas pulled at my heartstrings a little bit, but we came back home.
You practice otolaryngology.
That's correct.
I've been practicing. I said it right.
You said it right. Very good.
What does that encompass as a whole, the practice?
Yeah, it's also known as ear, nose, throat, and allergy, and we basically treat just about anything above the head and neck. We do tonsils, we do sinuses, we do dizziness, we do hearing and hearing aids, ear surgery, and unfortunately head and neck cancer as well.
Addressing the sinuses, what are our sinuses and why are they so important to us?
Sinuses are actually pockets of air, and we have a little model I think we'll get to show you a little bit later where we show you where the pockets are, but you have them behind your forehead, you have them behind your cheeks, and you have them between your eyes, kind of a little honeycomb appearance between your eyes. And if you drew a line straight through your nose, between your eyes, and straight through your ears, where those 2 lines cross in the center of the head, they're sinuses. What they do is, it's been debated for a long time. We think that they help lighten the head so that you can walk upright. That's one of the theories. But what we know they do, and what we're beginning to know even more recently that they do, is they're part of your immune system. And they secrete substances that help fight colds, help fight bacteria. And actually, even over the past 3 or 4 years, we're finding that they contain gases that probably help you breathe in and out and into your lungs.
So it's safe to say that they are essential to help us stay healthy.
They are essential to help us stay healthy.
Very interesting. Now, we're going to talk about the different types of sinus problems. Acute sinusitis, chronic sinusitis. Of course, we're in East Tennessee taping this, and it seems like our state, for some reason, suffers more sinus problems than people in other parts of the United States.
We are one of the highest. That's correct. There's several factors that play into it. One of the factors is genetics, because we do know that genetically people are predisposed to allergies, and if they're predisposed to allergies, that's one of the underlying causes of sinus disease. The other thing is we have a higher incidence probably of reflux, which also can contribute to sinus disease. And then finally, in East Tennessee, we have the greatest variety of flowering plants, grasses, weeds, and trees than any place in the nation except Hawaii. And so there's an awful lot of pollen that's out there contributing to this. And in East Tennessee, and particularly in the Knoxville area, we sit in a basin, so our air quality can decrease over occasion.
Very interesting. Now, what can we do when we're on the interstate and that big sign over the Interstate says air quality poor today.
Call us.
Or
No, no. There's several things to do. One is to be aware of what's happening, because sinus and allergy disease is something that most patients will ignore because they're used to the sniffy running nose, they're used to having problems, and then they ignore it long enough they begin to get chronic severe disease, and that's what brings you into the office for surgery and for other problems.
Very interesting. How many people in the United States actually suffer with sinus problems?
Everybody. No.
For your practice, you would.
Really. That's not exactly an exaggeration. At some point in time, probably everybody has some degree of sinus and allergy, even if it's just a cold. And that cold causes congestion, and you'll feel the pressure and pain. But by and large, I don't know the actual number of participants that are going to come in complaining of sinus disease.
What is considered to be acute or even short-term problems?
Right. An acute problem is a sinus infection that you have. Maybe you picked up a bacterial infection, or maybe you picked up a viral upper respiratory infection and you have congestion. We usually assume that if you've had it 4 weeks or less that it's an acute problem. It resolves, it goes away. Then we have, you mentioned chronic.
Right.
We have actually, sometimes we'll call one chronic acute, which means that you have an acute, you clear up, 3 or 4 weeks later it comes back. And so it looks like you're having an acute infection, but because you're having it repeatedly, it's really chronic. And then the actual term chronic means it's just there all the time. You never seem to get rid of it. You always have pressure headaches. You always have drainage and congestion.
So is there an average duration that someone suffers on the average?
It depends on the cause, but that's a very good question. It depends on the cause. If the cause is allergies, and let's say you're allergic to ragweed, well, ragweed will pollinate in the spring, and then it pollinates again in the fall. So starting in mid-August is about when we'll begin to see the ragweed level come up enough that patients begin to complain. And that will continue until we have the first killing frost. And once the first killing frost occurs, a lot of times we'll see their symptoms go away. Well, that's a chronic problem, but because it's partly allergy and partly sinus, it is directly related to the underlying pollen. Otherwise, some patients will have it usually 3 to 6 months, but we have patients that have it every day.
So this can be, I guess, a very expensive cost for Americans as
It
a
can
whole.
be extremely expensive. As you'll recall, before we started, we were discussing the numbers, and it's about $8 billion a year in healthcare costs for this, and 56 million work hours. So it is actually the #1 cause of loss of work time. You know, we think of back pain, we think of heart disease, we think of lungs, but actually sinus and allergies, the #1 cause in America of loss of work time.
When you are able to treat it in your practice, how do you actually treat it? What are some of the medications that people are prescribed commonly for sinus problems?
Right. That's a very good question, because there's a whole broad series of treatments that you can do. And one of the things that I like to talk to my patients about, and again, being from Tennessee, I use local colloquialisms, is what I call the beaver dam scenario. Okay. The beaver dam scenario is you're a farmer, you have a creek on your property, creek's running smoothly, it's flowing well. Beavers come along, they build a dam on the creek. Once they build that dam, it backs up. And where you used to have good farmland, now then you've got a pond and you can't produce on it, and the beavers are creating problems. So you need to go in and blow up the dam. If the farmer blows up the dam, then it'll flow freely for a while, but the beavers will rebuild it. If the beavers are relocated by the farmer, he still has the pond to deal with. So you have to both blow up the dam and relocate the beavers. You can't do one or the other. And that's crucial to treatment, because if I have sinuses that are blocked and obstructed, that's the dam. And if I go in and treat them surgically or medically, either one, but I don't treat the underlying cause, then the patient will be back in the office. And one of the reasons that patients get the false impression that they really don't get an improvement from surgery or from other treatments is because somebody may blow up the dam, they may do the surgery, but they don't treat the underlying cause.
Right.
And so the problem comes back in 3 to 5 years. Medicines that we use vary. We use everything in patients that are allergic. We use antihistamines. We use allergy shots. We even do a thing called sublingual immunotherapy, where instead of the shots, you take drops and you put them under the patient's tongue, and that builds up the immunotherapy. If the patients have reflux, we try and control that. We'll put them on medicines to thin out their secretions, steroids to decrease the inflammation, and try to open up the passages. And part of that is to open the dam. Opening the dam doesn't necessarily mean surgery. If I can open the dam with steroids and medicines, you may not need a procedure.
When a patient comes to see you, can it be, I guess, challenging at times to determine if it's a cold or allergies or if it is a sinus infection?
Well, interestingly enough, most of the time it's pretty straightforward, and it's because of the examination. When you look at the inside of a person's nose, what you'll find is with an acute infection, most of the time it's inflamed and red. But with a chronic allergy, it's usually blue. And the reason that you see the blue color is because the blood is sitting there, but the chronic congestion causes prevents the blood from leaving the area. But the oxygen leaves the area. So the oxygen's used in the tissues, then the color becomes blue. When I'm teaching students and residents, I will tell them that you can really walk down a grocery store and determine who has allergies and who doesn't almost just by looking at them.
At what point do you determine that surgery is probably the best option for a patient?
When
the
everything
antibiotics
else
aren't
fails.
working? Right. So you do try everything else.
Right, when everything else fails. Surgery should be the last option, not the first option. Having said that, we do a lot of surgery in Knoxville because we have such huge number of patients that actually have this disorder, and it's difficult to treat on occasion.
I want to talk about one of the latest technologies. Very popular. We were talking about it before we started this interview. Balloon sinuplasty.
Yes.
Sounds like a pretty complicated thing, but what actually is it and what is the purpose of it?
This is really one of the best innovations I've seen since I've been practicing. And what we do with the balloon sinuplasty is we open up the natural opening in a more natural way. In the past, when you would come in, let me go back and kind of give you a history. We'll go back about 35 years ago.
Sure, please do.
35 years ago, the methods of surgery that we did on the sinuses were somewhat barbaric. And we would go in, we would make holes under the cheeks and make holes into the sinuses and make incisions along the side of the nose, and we would open these things up and try to get in to clean the sinuses out. When we made a hole in the nose that went into the sinus behind the cheek, we tried to put that hole as low down as possible so that gravity would pull it out. What we didn't know is the sinuses have little brooms in them that we call cilia. Right. And those brooms swept everything out to the natural opening. So we could have a huge window in the sinus, but if it wasn't at the natural opening, it didn't matter. It wouldn't drain because the brooms are trying to sweep out the natural opening. You can have a hole in the wall, but if the woman of the house is wanting to take and sweep everything out through the door, it's not going to go through the hole. Right. So, you know, my wife is real meticulous. We actually have a vacuum cleaner at Central, but if that's what you're going to do, it's not going to work that way.
Right.
What this did is this basically about 25 years ago, 30 years ago now, a method was brought to this country from Ireland, a fellow by the name of Kennedy, and Dr. Kennedy brought a method where you could go in endoscopically and open up the natural openings. And he is the father of endoscopic sinus surgery in this country. About 7 years ago, Dr. Kennedy and I were sitting across from each other at our board of directors for our national organization, and people were presenting to us the idea of the balloon sinuplasty. And Dr. Kennedy and I looked at each other because we were friends, and I'd done a lot of sinus surgery, and we were both sitting on the board of directors of the academy, and we were really looking, thinking, I am not sure this is going to work. I mean, we had a very, very skeptical eye. To make a very long story short, I began to do these about 6 years ago here in Knoxville, and our group was the first group to do it here. At the time we started to do it, we were confining it pretty much to the frontal sinuses, which are the sinuses behind the forehead. We would go in with a wire guide, pass that wire into the sinus, follow it with a balloon into the sinus. We dilated the balloon at the level of the natural opening. By doing that, it would crush the bone, but not destroy the lining. In the old days, even with the endoscopes that Dr. Kennedy brought to this country, if you went in, we used instruments that would destroy the lining. So if I created a large hole, but the lining had been destroyed, what would occur is as it scarred down, it would close again. And that was a recurrence of the problem. The lining is made of mucosa, which is very elastic. It's very stretchy. So the balloon allows me to open up the bone, but not cause the scarring as much. And this is just a phenomenal technology. The other benefit to it is it forces me to be a better surgeon, because in the past, even with the endoscopic procedures, you could go in and poke the hole in and still not be at the right location.
Right.
And the brooms that are in the sinuses are still wanting to sweep it out the natural opening. So
this has been compared in many ways to the balloon for angioplasty.
absolutely.
Is that a good comparison?
It's not only a good comparison, as I understand it from the people that developed this technology, that is where they got their idea, was actually from the angioplasty.
Is this regarded as safe? I mean, is it effective and safe?
It is effective, and it is so much safer even than what we've done and what we do in our traditional surgeries. And we still do traditional sinus surgery. But when you do traditional sinus surgery or even the balloon, you're right next to the eyes, you're right next to the brain, and neither of those structures can be injured. With the introduction of the balloon, it has enabled us to be able to dilate these structures, to go in and open them up with just no real risks to the brain, no real risks to the eye. A surgeon that's used to being there should be able to do this procedure pretty confidently without any injuries at all.
How long does the surgery take?
Oh, it varies. In the hospital, of course, we're putting you asleep. We have the prep time for that, and you're probably looking at 20 to 45 minutes. In the office setting, the prep time is about 45 minutes of prep time while we're getting your nose to where you don't feel things, and the procedure itself usually runs about 10 to 20 minutes.
How do you determine if it's best for the patient to go into the hospital to have it done, or if it's going to be okay to do in your practice, in your office?
Right. That's an excellent question. And it does vary. I would say that in my own practice, I use about 3 different criteria. Number one is sometimes the insurance won't allow you to do it in the office. So if they don't allow you to do it in the office, you have to do it in the operating room.
Interesting.
Number two, however, is you have some patients that are just too high risk to put to sleep, either because of their heart disease or their lung disease. You just really want to try and avoid putting them to sleep. On the other hand, if you're doing something that's really no more invasive in many ways than a bad day at the dentist, you can do this in the office, and it's safer for them than it is putting them to sleep. And then the third thing that you have to look at really is, can the patient tolerate this in the office? Is the patient of a personality type that they are okay with doing it? And it's interesting because when you begin to do this on some patients, you will see that some patients really aren't enjoying the procedure, and other patients act as though nothing has happened at all.
So what is the success rate of balloon sinuplasty?
That's a good question. I will give you my own personal experience.
Okay.
In my own personal experience, to tell you how well this works, we have had patients that in the office, when I've done the balloon, of course they're awake in the office, that's the reason I'm using this as an example. I have actually gone in, dilated the balloon up, and as soon as it's been done, the patient goes, wow, it's open. One patient had had 3 previous surgeries by other physicians, and we dilated it up, and as soon as I inflated the balloon and deflated it back, he looked at me and said, that's it. He said, it's gone. It's gone. So of the roughly 60 to 70 of these that I've done in the office, I've only gotten results less than what I desired or less than what I thought I would in about 3.
Good statistics.
Very good statistics.
And what do people say if they come back a week, 2 weeks later? What do they tell you? What kind of feedback do you get?
Yeah, you know, I'm glad you asked that, because one of the important things that I do in my practice is we give everyone a SNOT 20. Now that's what it's called, SNOT 20. And it stands for Sino-Nasal Outcome Test. And it's 20 questions. When you come in for us to do your procedure on you, because I know you're going to be in after hearing this, what we'll do is we'll have you fill out a questionnaire, and it's 20 questions. And you grade the symptoms that you have from 0 to 5. So I give you that before we do anything on you, before we do procedures, before we do allergy testing or anything else. After we do this procedure, we give it to you again 2 weeks later. Every one of them, even the 3 that I wasn't satisfied with, every one of them drop their scores. And we see patients dropping their symptom scores, answering questions in the 4s and 5s, and they will drop them to 0s and 1 every time. And so that's the way that I monitor whether or not it works well.
Interesting.
And the numbers and the statistics we're getting are just really quite phenomenal.
Putting yourself in the place of the patient,
Mm-hmm.
what questions should they ask if they're considering this procedure?
The first question probably is, why do I need the procedure? And most patients, when they come in, will already know why they need it, because they're usually there for the headaches that they're having, the pressure that they're having, or just this constant drainage. One of the patients I saw this morning before we came here to film this was a patient that had the sinus balloon procedure about 3 weeks ago, and she was back in for her follow-up today, and the drainage that she'd been having, she says, it's gone. I'm not coughing, I'm not waking up at night with this, it's gone. And so by asking why they need it, I can go through the symptoms that they're having that they may not know are related to the problems that we're seeing.
When you do traditional sinus surgery, there's, I guess, the possibility of removing bone or tissue.
Correct.
And this is really great because that isn't necessary for you to do, is it?
That's correct. If we're doing just the balloon, we don't remove any bone or tissue. We just dilate the openings, rinse out and wash the sizes where we need to. Now that doesn't preclude removing tissue, and sometimes we do kind of a combination of the traditional and the balloon.
So what is the pain level like for the patient with the balloon procedure?
Before, during, or after?
All three.
Okay.
Well, before we know. I mean, that's
right,
why
before
they
that's
come
why
to
they're
see
here.
you. Yeah.
During the procedure, I've had some patients that really don't have any pain. Of course, if they're asleep in the operating room, they don't feel any of what we do.
Right.
And the patients asleep in the operating room, we've done this procedure on them. We have had patients literally in the post-anesthesia care unit, what we used to call the recovery room, that will tell us the headaches are gone. They wake up and they can tell they are gone. And then in the aftermath, even the patients that we have done in an awake or mildly sedated fashion that had discomfort during the procedure, in the aftermath, all of them say the pain's resolved.
Are there other advances in your field that you see maybe that are coming around the corner or somewhere in the future, like the balloon sinuplasty?
Yeah, I think the balloon is probably a technology that is a huge leap and a huge change, and it changes the way we do things, not only because of the technology, but because, as I said, it forces the surgeon that maybe has not been quite as smooth at getting into the natural opening, forces him to get to that natural opening, and so I think that's one of the big reasons. But there's other technology that's on the horizon as well. Some of the technology and some of the things that are coming about may seem minor, and some of them may seem major. A lot of the, of course, genetic testing that's going on today, I think is going to make a huge difference in the future, so that we'll be able to maybe pinpoint this patient will do better than that patient in one way or the other. Some of the allergy technology that's coming out is going to do a little bit better in that respect. One that I'm actually dying to use is, and this isn't sinus and allergy, but it is in my specialty. In the old days, if you had what we call a salivary gland stone, in the old days we would either take out the gland or open up the duct. Now then there's a tool and an instrument that we can dilate the opening of the duct, go in with a basket, grab and pull the stone out. And these are technologies that are there and are available that we're certainly investigating and planning on bringing to Knoxville.
My last question for you, when a patient is looking for a qualified ENT, what do they need to look for?
Us. No. No, there are several things.
Obviously, this is going to be seen on the other side of the stage,
right.
So that's important.
Right, it is. And
obviously certified.
They need to look for someone that's board certified.
Right.
They need to look for someone that's in good standing with the American Academy of Otolaryngology Head and Neck Surgery Associate, or Head and Neck Surgery, which is our national organization. But the other thing that I would recommend that they look for if they're looking for an ENT is try to look for the specifics of what they need, because many of us are becoming subspecialized. And that means we have other boards and we have other things that are subspecialized. Most of us and all of us do the broad variety of everything. But if you're coming into someone that you know you need allergy, then I would try to make sure he's a member of the American Academy of Otolaryngologist, which is our national allergy association. If you're looking for someone and you know that you have a severe ear problem that is what we call a neurotologist problem, such as a cochlear implant, then I would try to make sure that that was a neurotologist doing it. It doesn't mean that other physicians can't do it, but if you've got a problem, it's always nice if there's someone in your area that deals with this a lot to go to them. For instance, if you had a head and neck cancer problem, we do head and neck cancer, but one of the best facilities in America is at Vanderbilt. So this is one of the places we refer our patients to. It's good to know that you are seeing a physician that's done a lot of what it is you want them to do.
Very good information. Thank you so much for your time.
Thank you. Appreciate it.
A real pleasure.
Thank you.
Wish you much continued success in the future as well.
Thank you.
Some very interesting information that Dr. Leonard Brown shared with us. Now we know it is not only speculation that Tennesseans have their share of sinus problems. You also heard about a new treatment that now exists. If you are one of those sinus sufferers, I hope you learned something that may help you in the future. Thank you so much for joining us. Up close, I'm Chris Williams.
Up Close with Chris Williams is presented by Tennova Healthcare, with 6 hospitals and more than 1,000 dedicated physicians. For more information, tennova.com.